Hello, everyone. I'm delighted to talk about the CMV guidelines tailored specifically for the Indian transplant setting. And this will be highlights of the 4th International CMV Solid Organ Transplant Guidelines. We recently, a year ago, had the 4th International CMV and Solid Organ Transplant Consensus meeting. There was a lot of work that went into this. This is a tremendous review of all of the world's literature on CMV and solid organ transplantation. You can see we had a lot of participants. As per all TTS events, we had participation from all around the world, and all different TTS regions were very well represented. We had 6 different working groups, as you can see here, all the key features of CMV management, and I'm delighted that we had Drs. Sumita Bagchi from AIMS and Dr. Priscilla Rupali from CMC Vellore as participants and very active voices in the process. So this was published in the July issue of Transplantation, and each time these are published, these are usually the most highly read article that year in the journal Transplantation. CMV is the most common infection after solid organ transplantation. It is a latent human herpes virus, and interestingly, if you look at the literature from Europe and North America, only about half of adults are CMV positive, but in India, it's estimated that at least 95% or more are CMV positive. And these days, we have really good but not perfect prevention methods. It can cause a spectrum of disease, and then resistant refractory disease and difficult to treat adds a major burden, and I'll talk more about that. As I'm sure you know, there's currently a range of CMV from asymptomatic to CMV syndrome to CMV disease. And all of these can have either an increased risk with more immunosuppression or at the end of prophylaxis, or if there's new exposure later on. But there are many ways of overall decreasing the risk of CMV infection, as you can see listed on this slide. CMV has both direct effects, which are bad, but also the indirect effects. And the indirect effects of CMV can be quite severe and result in negative impacts both to the individual patient, but also your program. So you can see there are higher risks of all types of infection, PTLD, new onset diabetes after transplantation, immunosenescence, acute rejection, and mortality. And then there can be specific negative impact on the transplant itself, as listed here. So in a recent review, Dr. Paul Griffiths, who's one of the grandfathers of the CMV and transplant field, said that the total amount of morbidity caused by the indirect effects of CMV may exceed that currently attributed to end organ disease. So CMV is in fact really bad. There's a lot of data out there. For me, this is one of the more convincing ones. This comes from the United States National Database. And as you can see in the figure, people who are at high risk for CMV, donor positive, recipient negative, high risk scenario, they have a lower overall survival compared to what is most common in India, donor positive, recipient positive. So even with excellent prevention methods, CMV has a very negative impact on the overall survival and graft outcomes. Again, the highest risk scenario is donor positive, recipient negative, and the second highest would be donor positive, recipient positive. And I know that very rarely do you see donor negative, recipient negative in India. I would caution that I think that you are at risk for seeing more CMV seronegative adults. I've been told that in some programs you don't even check CMV serology because you assume everyone is positive, but you do really want to know who is donor positive, recipient negative, and it may be people who are CMV seronegative are more likely to be those in higher socioeconomic stratas or with improved sanitation and less crowded living situations, or who have limited exposure to young children, younger age, or who have been brought up abroad. So I think be ready for this high-risk donor-positive recipient negative population, which is about 25% of what we have in North America. In the guidelines, we do recommend checking donor and recipient serology before transplant purely for risk stratification. We don't recommend checking CMV IgM. It's not been shown to be useful. And we don't recommend using serology to look for active disease. It's purely for risk stratification. We do recommend using PCR testing that's calibrated to the WHO standard, and either using plasma or whole blood, but not alternating between those, and picking one testing platform and sticking with it. We also recommend, rather than looking at the number value, we recommend using log changes in CMV because this will help you avoid overinterpretation of the results. A significant change would be at least half a log, although if it's 10 to the third, then it needs to be 0.7 log change. As you can see for these numbers in this figure, those in green represent significant log changes. So, 300,000 down to 100,000, et cetera. But many of those in the lower part of the grid are actually not significant, but the numbers look significant. So I get a lot of messages about these numbers, but actually these numbers are actually technically all the same. There's overinterpretation of these changes. So if you use log, I think it'll decrease overinterpretation. For prevention, there are two main methods, either antiviral prophylaxis, which I think throughout the world is the most common. It's also acceptable to do weekly testing for 8 to 12 weeks, 12 to 16 weeks after transplant, but I know in the Indian context you're not usually doing that, but antiviral prophylaxis works quite well. One thing that came out of the second version of the guidelines that can be quite helpful is for people at high risk for CMV, you can use a hybrid strategy where you give 3 to 6 months of prophylaxis, and then afterwards you start weekly testing and you capture CMV before it becomes severe. This is especially useful with the donor positive recipient negative situation or where there's intense immunosuppression, and that may be where there's highest yield. This is really important to think about the net state of immunosuppression, and for those who have high immunosuppression, again, they may benefit. So we have guidance in the most recent guidelines. This actually has not changed from the last version of the guidelines, but for seropositive kidney transplant recipients, we recommend 3 months of valganciclovir. Think about longer if they're more potently immunosuppressed, but in general, 3 months is fine. Donor positive, recipient negative is 6 months, but the majority of kidney transplants here would just need 3 months of valganciclovir. Liver transplant is similar time spans. We do see a lot of leukopenia after transplant, often because they're on multiple medications. One of the most important things is not to cut the valganciclovir dose in half. That will potentially result in antiviral resistance, which has very high morbidity and mortality. It's better to stop the valganciclovir entirely and either do weekly or biweekly monitoring. If you have a high absolute lymphocyte count, say over 1,000, those people aren't likely to develop CMV. Especially if they are seropositive. And if you have access to a cellular-mediated immune assay, I'll talk more about that, you could use that to detect their overall risk. Valganciclovir dosing is really important. Unfortunately, it's really heavily reliant on calculating an appropriate level of kidney function. And just to know that for the package insert, they use the Cockcroft-Gault formula, which isn't so heavily favored these days, but it's important to make sure you're using the correct GFR to correct the correct dose. I do want to say that in our program in the United States, we use for kidney transplant 450 milligrams once a day. This is not mini dosing. This is because the majority of our kidney transplant recipients have creatinine clearance of 40 to 59. So I don't ever recommend mini dosing, but I do recommend appropriate dosing, and I think this helps avoid a lot of leukopenia. We have a new drug approved, letermovir, which I know is available for stem cell transplant recipients here, and I've gotten a lot of questions since I've been here about letermovir. It is approved now in the US for high-risk kidney recipients. It has been shown to be about the overall same outcome as valganciclovir, lower rates of leukopenia, slightly lower rate of breakthrough infection, and lower rate of people discontinuing prophylaxis. What we don't know, this was a study funded by Merck, and what we don't know is what the true valganciclovir dose was or what the renal function was. So they have not been willing to release that information, and I have suspicions that the valganciclovir may have been overdosed in the study because this had higher rates of leukopenia and neutropenia compared to prior work. So this has been approved in the US for high-risk kidney transplant recipients. In the United States, it is $268 a day versus $5 a day for valganciclovir. So we are not using it due to cost. It also doesn't cover herpes or varicella, so we need to give it with acyclovir or valacyclovir. But very, very expensive, very limited use. We're actually using it in lung transplant recipients with short telomere syndrome and otherwise not standardly using it. So what did we say in the guidelines? You know, we write these guidelines where we recommend so much prophylaxis and monitoring and all of that for so many people. Can we personalize medicine? And the answer for the first time is yes. So there are some cell-mediated immunity assays. You'd be very familiar with the tuberculosis, you know, quantiferon TB, and so now they have quantiferon CMV, they have T-spot CMV, and then there's intracellular kind analysis with flow cytometry that can be used. And for the first time in these guidelines, we actually did say, predominantly based on what is largely Spanish data, but if available, we do recommend that you can use a CMV, cell-mediated immunity test in kidney transplant recipients to predict who really needs valganciclovir and who doesn't. Now, I know you may not have access to this test, but it is something to think about in that you could decrease their overall need for valganciclovir. And then we don't recommend use of this testing when there's a high-risk situation because in numerous trials, including the largest kidney transplant trial for which I'm the senior author, we showed that this testing unfortunately does not work. What to do about late CMV after the end of prophylaxis? So there are after the end of treatment. So we do worry that after treatment, people are at risk for rebound CMV. So we ask that people assess the individual risk for the patient. What is the CMV serostatus of donor and recipient? Have they had prior recurrences? Is the absolute lymphocyte count high or low? How immunocompromised are they? Do you have access to CMV cellular-mediated immune testing? Most people don't need secondary prophylaxis, but for some, you may wish to give another 8 to 12 weeks of prophylaxis, depending on overall risk. Okay, best treatment of CMV, I think you'd be very familiar with this. This has not really changed over time. For most mild to moderate disease, we recommend valganciclovir, renally adjusted. For severe disease, life-threatening disease, ophthalmologic disease, central nervous system disease, we do recommend intravenous therapy. We think about lowering immunosuppression. That's always a discussion with the transplant team. If it's a CMV seropositive recipient, you may need to reduce immunosuppression. They're often saying they're over immunosuppressed, that's why they had CMV. If they have hypogammaglobulinemia, you may wish to replete their immunoglobulins, and then you check them weekly, and once they've resolved the infection, you can stop the treatment. For those that don't respond to treatment, we do worry that they may have resistant refractory disease, at which point we need to think about possibly, if you have access, sending CMV resistance testing or switching therapies, and that's what I'll talk about now. So for difficult to treat CMV infections, you know, people who have either recurrent or refractory or resistant infections or treatment intolerant infections, this is a very small part of my practice, but it does take up a lot of my work. And this is basically because there's an immunologic inability to clear CMV and maintain CMV latency. Now, sometimes we need to have realistic expectations of what we can do with treatment. We know that people with very high viral loads take much longer to clear. And if we look at the trial that compared intravenous ganciclovir versus intravenous ganciclovir with valganciclovir, for those that had very high baseline viral loads, it takes longer to clear. So that's to be expected, no surprise there. Risk factors for difficult to treat CMV include the mismatched donor and recipient, higher levels of immunosuppression, especially people who are highly sensitized or have had recent rejection, older recipients, and we're now doing kidney transplants in many people in their 70s, or lack of prior CMV cellular immunity. Also, with the drug belatacept, we're seeing a lot of CMV. Longer exposures to antivirals increases the risk of resistance and side effects. Also, those with high DNA-emia at the time of antiviral treatment increases the risk of antiviral resistance, which is why we prefer monitoring rather than having severe disease. And then antiviral underdosing during prophylaxis is one major way to get difficult to treat CMV, and then some of the more complex transplants. We do have new definitions of resistant refractory CMV. Refractory CMV is basically when someone fails to respond either clinically or on blood work. And then resistant CMV is when you actually do testing and you find a known viral genetic mutation that conveys resistance. There are a variety of different tests you could do, CMV genotyping for drug resistance. Either Sanger sequencing is the classic, or now most labs in the US have moved on to next generation sequencing, which can detect as low as 5 to 10% of the total viral population. You do need to have a CMV DNA EMA of at least 10 to the third. I'll go through a clinical case, and I know that this is a little different than what you often see in India, but I thought that it might be informative for you just to hear the details of this case. She underwent deceased donor kidney transplant, CMV donor positive recipient negative. She had very complicated responses to the immunosuppression with a thrombotic microangiopathy from tacrolimus. So she was eventually converted to belatacept, prednisone, and azathioprine. She got the standard valganciclovir for 6 months. And then she had a low absolute lymphocyte count. She'd been frail and not doing well, so we knew she was at high risk. 1 month after the end of valganciclovir, we'd been monitoring her, and we finally detected that her CMV DNA EMA was 10,700. She was put on appropriate treatment dose valganciclovir, and overall had a good response. She was then, at the end, because she was quite immunocompromised, we put her on valganciclovir secondary prophylaxis. So while on valganciclovir prophylaxis, she has breakthrough CMV. This is bad, right? So she confirmed she was taking her medicine, she was on the right dose. So what would you do in this scenario? I think there are a lot of possibilities. I think the best would be in our context where we have access to this new drug called maribavir, which is very good for resistant refractory disease. You could start that or start foscarnet or cidofovir treatment. And I just spent time at CMC Valor and we talked about this and using either foscarnet or cidofovir for resistant refractory CMV. We don't recommend letemavir for treatment. High-dose valganciclovir usually does not work because she's resistant to valganciclovir. We do have a flow chart that's one of the most heavily used figures in this document where we recommend that people walk through, if you have resistant refractory disease, how to best manage and when to initiate things like foscarnet, and then how to incorporate genetic resistance testing into the algorithm. So as you can see, she had that viral load of 18,000. We started her on foscarnet. We switched the belatacept to cyclosporin. Once she'd had a good treatment response, we switched the foscarnet to maribavir and famciclovir. She continued maribavir and then letemavir for secondary prophylaxis for 6 months. We stopped it. She had a little bit of a blip of CMV up to 800. She got a dose of CMV immunoglobulin and her CMV DNA EMA resolved. So the teaching point here is that belatacept increases the risk of complicated CMV in high-risk patients, and we switched her to a different agent, and then she had a good response even in the setting of highly resistant CMV. She did have the M460V mutation, which interestingly conveys a high level susceptibility to maribavir. There are some additional therapies that we use for resistant refractory CMV, including IVIG or CMV immunoglobulin. Some people also use T-cell therapies, but there's not really conclusive data of efficacy. And then we don't recommend things like letemavir, leflutamide, artesunate, or mTOR inhibitors. There are some vaccines that are being developed. We're hopeful that this could be useful in both seropositive and seronegative populations. And we are cautiously optimistic that perhaps this triplex vaccine or there's a Moderna mRNA CMV vaccine that might be useful. So just in summary, there's been lots of progress against CMV. Diagnostics are better than ever. Valganciclovir has been excellent prevention and treatment, and certainly in India, I've seen the pre-valganciclovir era and now post-valganciclovir, wide-scale use of valganciclovir, which is great. The highest risk group, that donor-positive recipient negative, may be expanding in India. Don't be caught by surprise. That happened in Japan, where they always assumed people were seropositive and they had some bad outcomes. So we do recommend checking serology. We have many new tools in our armamentarium, which is great, but we do have reach limits sometimes. And because this is a disease of immunosuppression, would a CMV vaccine help decrease risk? And we're optimistic about that. If you want to hear more about CMV and complex cases, we had a great webinar. You're welcome to just listen to this. It's free and easy to access, and I did this with my wonderful colleagues here on the slide, including Dr. Atul Humar, who's also attending this meeting. And I'm happy to have questions by email. Follow me on X, and thanks a lot for listening. And also, I am so appreciative of the support of the Transplantation Society for all of the CMV guidelines, all of the webinars we're doing through the Education Committee, the BK guidelines, et cetera. Thanks a lot for your attention.